how might this affect insurability, or if other people look in the charts. And they worried about the accuracy of model predictions. Could it actually do a good job? And one of the quotes from the qualitative work we did from an attending physician in Atrius said, I think I should probably be offering PrEP to more people than I am offering it to. So in that way, these types of models would improve my practice and have me doing something I would like to be doing. We also interviewed patients to see what their thoughts were, not about these models in specific, but about using EHR data and risk prediction tools more generally. So we interviewed over 30 men who had sex with men at Fenway and Beth, Israel. And some of the themes that came out of this work was that they really wanted providers to contextualize information about HPV risk. If it was just delivered as a number, you're kind of in the red zone of risk, people would be really put off by that. And it would have to be done in a sensitive way that was in context and therefore useful. They did have doubts that an algorithm could ever quantify risk at a single point in time, meaning people switch relationships all the time. They may change their condom use on a dime. And so they wondered how a computer could keep track of all that. They did believe, however, that a tool that was useful could actually motivate behavior change. And that's something illustrated by this quote. I would think an HPV risk prediction tool actually could be helpful in a way. I mean, obviously I would take it with a grain of salt, but I think it would help me understand where I am, how I've been doing. Okay, do I continue on the course that I'm on, or do I need to adjust? And the rest of this interview talked about condom use and partners, and so they thought that the information could actually help with behavioral change aside from things like PrEP. Now, one of the things about the implementation side of this work is that very few prediction models across different areas of medicine are ever implemented, meaning there's a lot of people doing amazing work about how to make the best prediction models. And a PubMed search that we did showed that the orange the orange line here is the number of prediction model hits in PubMed. And you can see it has skyrocketed up through 2020. But in terms of things looking at prediction model implementation, it's remained relatively flat. And I think that reflects the reality that we need to think not just about how to make great models, but how do we actually get them to do what we want and improve clinical care and population health. So the USPSTF, in terms of HIV prevention and PrEP, has made calls for this type of implementation for HIV risk prediction tools. They want more implementation work to evaluate, does this actually make a difference in terms of clinical practices, as opposed to just having a nice AUC in the electronic laboratory, as it were. Now, the USPSTF gave PrEP a grade A recommendation, which is the highest recommendation in terms of net benefits versus risks. They did it in 2019, and then they reaffirmed it last year in 2023. So the data are very strong that this is a good intervention for people who are likely to benefit. But they did mention that instruments that are accurate for predicting risk of HIV infection could help inform decisions regarding the eligibility of PrEP. And they mentioned the tools that Julia and I had developed with our groups at Kaiser and also in Atrius in Massachusetts, that they had moderate to high discrimination, which was all good news. However, the caveat that they appropriately mentioned was that studies really are needed to verify the impact of using these in clinical practices. So, our hunch about the hard work of the implementation of these things and the USPSTF guidance coalesced around this next phase of work. So how did it all start? It started with something we called the PREDICT study, which was based on an NIH R34 pilot grant, where we wanted to pilot this clinical decision support approach in community health centers, given how important these centers are in terms of ending the HIV epidemic. So we partnered with OCHIN, which is a network of community health centers around the country. You can see the little dots on this map here. Each one represents a community health center that partners with OCHIN in terms of their EHR. So they have an Epic installation that's centralized, and it's fed to all these different sites. So it's a really cool kind of community laboratory to use EHR modifications and clinical decision support to see if you can impact lots of small practices around the country where they might not otherwise have the resources to do this kind of big resource-heavy work. So the first aim of the pilot study was to develop and validate an HIV prediction model using the EHR data from OCHIN specifically, basically recapitulating the same types of approaches we did at Atrius and that Julia and Jonathan did at Kaiser. And then we're going to build a decision support tool in Epic that embeds the model, and finally pilot it in a couple of health centers to evaluate feasibility acceptability, and then the early impact on PrEP prescribing in 3 clinics, which ended up being in California and in North Carolina. So the first thing we wanted to do was to look at how the model performed. And the lasso regression model had a pretty good performance with an AUC of 0.84. So you can see a theme across all these sites that EHR data tends to be really good at predicting HIV risk based on the AUC at least. And so we went with lasso, given the prior model seemed to work really well, and also because it's something that's parsimonious and readily interpretable by clinicians who might use these tools. Final model of OCHIN had 51 variables. And there were some issues in terms of model prediction, in terms of predicted better for males than females, and better for non-Hispanic whites than non-Hispanic blacks. So these are, again, some of the inequities that plague the HIV epidemic as well, and also PrEP use. So we wanted to really take that into advisement in terms of moving forward with a particular model. So the biostatisticians that we worked with at Oregon Health Sciences University were really creative at using some interaction terms to try and improve the fairness, but it did add some complexity to the model. So there's always that trade-off between simplicity and complexity. But you can see from these curves that there were some fairness issues that we tried to address. So our conclusion was that even though the models may not be perfectly fair, even with some sophisticated tweaks to the modeling, we might need to think about additional strategies on the back end to promote equity in these discussions. So when you actually give this to clinicians, can you use education and other strategies to make sure it's done in a way that addresses inequities? So we collaborated with OCHIN primary care providers and IT and informatics experts to build the tool in their Epic installation. And here are some screenshots just to give you a flavor for what it looked like. So there's a notification called a best practice alert or a pop-up that notifies a clinician at the point of care that the patient may benefit from PrEP. And it links to information about the prediction model and some facts about PrEP itself for clinicians who may not be as familiar with prescribing PrEP. And then it gives some language that's meant to be patient-centered and to help clinicians, again, who don't have their own sort of comfortable script to talk about PrEP in this context. And we use it based on a patient-centered framework called the GOALS framework developed in New York City. And it talks about different groups that are likely to benefit from PrEP to help clinicians be ready to offer PrEP appropriately at the point of care. And finally, it has all the nuts and bolts to kind of, pull back the bow and let the arrow fly as easily as possible in terms of prescribing. So it has order sets for the labs and for the prescriptions and even for the ICD codes, and even a templated note you can just plop in the chart. So kind of one click and it's all done once you make the commitment to prescribe PrEP. And just as a heads up, there's a new ICD-10 code for PrEP encounters. And so this is something that will be really interesting with HIV risk prediction models going forward. Now we can track when a clinician actually has someone on PrEP using a hopefully rigorously implemented ICD-10 codes. That's a cool development in terms of this electronic health records work. So we piloted at these 3 health centers, and along the way we did a lot of check-ins, so sort of qualitative check-ins with the providers. And let me walk you through some of the successes and then also some of the challenges that they cited. So the first success was that they thought that this tool facilitated identifying people likely to benefit from PrEP that may have been otherwise missed. They talked about, I won't read the quotes verbatim, but they talked about appropriate alerts and helping them think about patients that they might have missed. It supported discussions and prescribing for providers who might have been less familiar with PrEP. And they talked about how when you click into the tool, it's like all right there for people who aren't as comfortable doing this. It prompted providers to initiate discussions when stigma might have been a barrier to patients initiating those discussions. And stigma is just a huge barrier to these sexual health and HIV discussions. And this is a quote I think I will read because I think it's really quite telling. It says, in terms of HIV disparities and what's causing them, I think the tool is one of the better ways to identify patients and improve access to PrEP. And I think FQHCs need it more than any other type of healthcare organization, especially here in the South and the Bible Belt, where patients are afraid to tell providers anything about what they're doing. It also increased communication and relationships amongst providers and their own clinical staff. So it helped kind of catalyze discussions about HIV prevention and PrEP. What about the challenges? Well, some of the providers thought that the model identified patients who really weren't likely to benefit from PrEP, so-called false positives, and they weren't happy about having this pop up, and then they had to kind of grapple with a patient that they thought weren't really at high risk, but the computer was telling them that it was, and so what are they supposed to do? So that was something that we needed to address. We also thought that on the other side was false negatives. So some providers thought that the model missed patients who were likely to benefit from PrEP, which compromised their trust in the model in terms of its accuracy. So they said I was puzzled because there were obvious patients who were candidates for PrEP, for example, a young man with STD exposure, but they weren't targeted by the model. Some providers were also hesitant to act on alerts without more information about specific EHR variables that triggered the alerts for the patients, because they wanted to use those to introduce the discussions to their patients. So what are the top factors were things that they really wanted, and it's not something that we had provided in the first iteration of our tool. Okay, those are some of the challenges and early things they liked about it. One of the challenges around false positives that we tried to address was making sure we don't exacerbate alert fatigue, that is, flagging too many people. And so we actually started the model with a risk threshold that flagged about 17% of all the patients, because they had twice the HIV risk of the average patient in the OCHAN population and 20 times the risk of the US population. But the provider said, this is way too much. You gotta tighten things up. So we had a new threshold that only flagged a maximum of 5% of patients, and more typically 2 to 3%. And these patients had about 15 times the risk of HIV of the OCHAN population and over 100 times the risk of the general population. And this threshold, which kind of fit what we'd done at ATRIS, if you remember that curved I mentioned from our earlier work, this was really a much better fit according to the providers, and I think we had to listen to them. So we moved forward with this new threshold midway through the pilot project. One of the things we learned is to think about clinical decision-making beyond traditional heuristics. So one of the providers at a pilot site in LA called us up and said, your model, it's not working well. It's having all these false positives. And we said, can you give us an example? And they said, well, I had a 46-year-old cisgender female who was flagged for a PrEP discussion, but she's married to a male partner. She drinks alcohol. She lives in LA County and identifies as Latina, and she had an HSV-2 diagnosis years ago, but there's really nothing in her chart and in my history that suggests HIV risk. So I think the model is not, shouldn't be flagging her. And so the question is, should clinicians always prioritize PrEP when the model says so? Now we know that the model is a rational and accurate in as much as it does identify people accurately who went on to get HIV in terms of historical EHR data, but it may not be perfect in its performance. I think what we learned is that clinicians, like myself, are trained to work on heuristics, mental cognitive shortcuts to try and get things done well in clinical practice. And they're really good for things you need to do quickly. They're automated, but they're error prone, and they can be, prone to unconscious biases. Whereas the rational thinking, like an EHR decision support tool, is takes a lot of effort and it integrates complexity, but it's much more reliable. And so how do you balance this when trying to get clinicians to trust these models? Well, one thing that we realized is clinicians said, if I don't see these traditional HIV risk factors, like someone had a syphilis diagnosis or identifies as a man who has sex with men, then they really wouldn't trust the model. But we found some data that was really helpful, which is that in OCHAN, of the 6,182 new HIV diagnoses in the data set we used to develop the model, only 2% or so had a prior bacterial STI in their EHR chart at OCHAN, meaning if you just went based on STIs, you'd miss 98% of the opportunities to prescribe PrEP and prevent a new HIV diagnosis. So I think some of these data-driven conversations really helped people understand why sometimes the traditional heuristics might fall short, and might there be an integrated model that's even better. And so we actually came up with something that we call the blended model, where we flagged patients if the EHR model identified them as at increased risk using the LASSO model. But we also said if the model missed them, but they had these classic traditional risk factors, being MSM or having gonorrhea, syphilis, or chlamydia diagnosed in the past, we'd still send the alert. And I think the providers were much more comfortable with this approach because it acknowledged the traditional heuristics and also the EHR-based approach. Now, some providers really want to know how this all worked. And again, they wanted to know specific variables, which we didn't do because it was very complicated to program. And some of the variables were not clinically intuitive. And so we created this sort of, why am I seeing this alert, which is based on a nutrition label, which came out of your group. So we're really thankful for the paradigm that you all pioneered. And so we developed our own predict study version of this that talks about what the alert is about, what variables go into the model, how you can use it as a clinician, and what the study is all about. So we did an interim analysis on feasibility and preliminary impact at the 3 health centers after about 7 months of running the model in January 2023. And at that point, the alerts had fired for about 2% of 33,000 patients who had been seen at those health centers. And PrEP prescribing still remained quite low. It was very, very low to begin with, and it was still low afterwards. But there were some promising statistical trends. There was almost 5-fold higher PrEP prescribing in the intervention clinics versus some control clinics that we matched. And we saw a small increase in HIV testing that was not statistically significant in those clinics versus their matched controls. So some early promise that was nice to see. But the final analyses have been ongoing, and we've moved on to a larger trial that's going to be funded by the National Institute of Mental Health, which is an R1 proposal where in the first aim, we're going to expand the tool to support not just flagging people for PrEP initiation, but also expand the tool to help with follow-up care to get people retained in PrEP care and persist, which is really where the benefits in the long run occur. And then we're going to conduct a stepped wedge trial in 16 of the Ocean Health Centers to quantify the impact on PrEP use and persistence, and then also use some quantitative and qualitative methods to explore equity in how providers select patients for PrEP based on use of these models. And just to take kind of a broader view of how this approach has been used around the country thus far, the Massachusetts Department of Health is using the H-risk prediction model to try and help clinical sites around the state to think more about PrEP in their practices. So it's in real world use as we speak as part of the DPH practices. At Duke, as I showed you from the Burns et al. Paper, there are really great projects to try and use this model to impact care in North Carolina. We've worked with Jefferson, Mobile counties and their departments of health in Alabama to develop the same kind of tool that's being implemented. There's also work from Meredith Clement, formerly of Duke, in terms of doing this work in Louisiana. We have colleagues at Parkland Hospital in Dallas, and we're also developing an EHR prediction model in the Dallas County Jail with that group. And then Jonathan and his team at KP Northern California and San Francisco have done more work in terms of implementing their models as well. And really welcome him to chime in as well about his experiences, which have been incredibly helpful to learn about the types of providers who are most likely to see this kind of alert and take action. Spoiler alert, that's people who already have experience with PrEP and HIV as opposed to generalists, but really important work from Kaiser as well. So to conclude my portion of the talk here, community health centers are critical for scaling up PrEP as part of the national federal programs to end the HIV epidemic. And EHR tools in these venues, as well as many other types of settings, including departments of public health and academic medical centers, maybe even places like jails and other settings, can be used to prompt more efficient, equitable discussions about PrEP and hopefully more effective prescribing. Decision support for HIV prevention and sexual health and substance use related disorders can facilitate PrEP provision in primary care. Some of the piloting work is promising that this is acceptable and feasible, and but we really need these bigger studies, which we're hoping to embark on as part of, for example, that R1 study, to really understand if implementing these tools actually makes a difference on PrEP prescribing and then ultimately the HIV epidemic. I want to acknowledge our collaborators at Harvard and Fenway, at OHSU, at Ocean, and our funders in terms of the National Institute of Mental Health. And I will stop there and welcome questions and comments from the group.
Thank you so much. That was a very engaging talk. I'll open the floor for any questions from the group. Yeah, go ahead, Charles.
Hi, it's Charles Binkley. I'm an ethicist. I study AI used for clinical predictions. I'm used to hearing developers and programmers talking about these models, so it's really nice to hear another clinician talk about them. I'm a surgeon by training. I have myriad questions, but really the thing that comes to my mind, I'm working with a group at Georgetown University on a similar model, or at least Georgetown's working on a similar model, and I've been sort of thinking with them about what are some of the unintended uses of it. And one is particularly in areas that may be hostile to people who have a high risk for developing HIV and would be candidates for PrEP. There can be political structures that are opposed to them, or there could be sort of a desire to segregate or to bias them. And so this prediction could actually backfire, right? So just as you're trying to use it to help, it could actually be harmful. The other way in which it could be harmful besides stigma is discrimination on the basis of denying somebody who may have risk factors for HIV, but because they don't fit into the model says no, and so they're denied that. So how do you think about these? So my role is really to think about unintended uses. How do you think about unintended uses in that context? And then also sort of as a corollary, how do you think about the obligation to offer? So for instance, you show that really very important inflection point where this is a group of patients who are at really, really high risk. How do you manage that group, particularly around the clinician response? So for instance, in my mind, you are ethically justified if we've identified people at very high risk for something. We have an ethical justification to inform them that they're at high risk, particularly if we can mitigate that, right? So if a clinician gets this BPA or however it comes down the pike to them, and they simply say, I'm not comfortable, I'm going to ignore this, I still think we have an obligation to that group of patients. So sort of how do you think about these kind of categories of harm?
Charles, thank you for these really rich questions. And clearly you've been recording my personal nightmares about this work as we've been going through, because first do no harm is absolutely at the forefront of our thinking. So we certainly don't have all the answers, but let me tell you at least our thought process in terms of the stigma and also the idea of people not being offered PrEP if the model doesn't flag them, and a clinician saying, hey, the model didn't identify you, so you can't be at high risk. I think that our thinking as this is how we frame it when we implement it with clinicians is very, very important. We are framing this as what we've sort of called a first stage screener, meaning this is not truth. This is a way to help clinicians improve their practices about something that has really been done very, very little in most primary care practices. There's almost no discussion of PrEP, as I showed you some of the data. And so we explicitly tell them, just because the model doesn't flag someone doesn't mean they're not a great candidate for PrEP. We also tell them that the CDC recommends they talk about PrEP with all sexually active adolescents and adults, and that is the aspirational goal. We also say that we acknowledge that we know that that's a long way off, given how busy people are and the level of training. And so you'd be asking a lot of people about PrEP with no traction, and that providers have told us they're not quite ready to do that. And so this is a way to tell people, well, for some people, seatbelts and talking about cardiovascular risk prediction is like clearly the number one thing. And if the model sends a flag, an alert, we hope that they can think that for this particular patient at this point in time, that PrEP is actually, hopefully it's something they can prioritize, but not to forget other things and not to leave other people out. So we try and frame it as a tool to help them, but not the end all be all. In terms of, people being more stigmatized because of the political nature of these environments by the model flagging them, that's also something that we really have to work very closely with clinicians on the front lines to do appropriately. Our collaborator in one of the community health centers in North Carolina, we have kind of a champion there who's really excited about PrEP, but told us and gave us that quote about the Bible Belt that I recounted in the presentation, told us that, guys, we really love your model, but we have a culture problem here that your model is not going to solve. I have providers who would never talk about this, no matter how many times the model flagged them. And so what do we do? And so we don't have all the answers, but what we've tried to do is say, let's work with you and you tell us what we can do. And I think part of it is that he came up with was, well, what if instead of asking providers who are uncomfortable with this or may actually sort of exacerbate their tendency to say things that are stigmatizing or insensitive, what if for those providers, when the alert comes up, you come up with a practice flow where they don't actually bring it up at all? What they do is they click a button that then refers the alert back to you as the PrEP champion, who's someone who is identifies as someone who's very comfortable with PrEP, wants to see PrEP patients, and can kind of work with their colleague to step in and provide a much more sensitive, highly trained person to have these discussions. Now that ain't perfect either, because how do you outreach to a patient and say you're getting this call from some random provider? And so I think it's still a work in progress, but we're trying to let the frontline clinicians, lead the way, as opposed to us telling them how it should be done, to do this in a way that kind of meets their local sensitivities. Another thing that I think addresses the third point about the ethical obligation to let patients know is that we're trying to use one of the EPIC features in this R01, what we're considering, if we can get kind of approval, to have the patient sent a message directly through the patient portal. Now, if we said, hey, our computer, just like the New York Times thing, the computer said, you're screaming with risk and come on in and talk to us about PrEP, that would be obviously an ethical and clinical disaster. So that's not the idea. The idea is to think about a way to say to people, hey, we're trying to give people the best quality of care in all realms of preventive medicine. And we know that there's a whole new area of HIV prevention that we could do a better job at. And we want to make sure everyone has information so that they are empowered and informed to make the best decision that's right for them. This is, HIV testing and PrEP is da-da-da. So you can imagine where we're trying to make it so that people don't feel singled out. Now, are they singled out? Well, it depends. I mean, you could imagine sending that information to everyone through the portal. But again, then you lose some of the benefit of tailoring it so that people have salience. So all works in progress where we have, I think, people like you, Charles, on our shoulder constantly. We're trying to channel experts like you as we go through this. And I think my request would be to please, engage us, given your expertise, which we don't have, and help us do this in a way that meets the ethical obligations and also makes clinical improvement. Because one thing we don't want to do is say, cardiovascular risk prediction, nobody says anything about. No one says you're going to stigmatize people by saying you're at risk for heart attack, so take a statin or an aspirin. No, we just go do it because it's good for people. This is all about HIV exceptionalism. It's stigmatizing as a whole condition. We don't want that to push us to the sides and the margins. So I think that's why the sensitivity can't stop us, but we have to account for it. Does that?
Yeah, that's super helpful. I mean, we certainly see that exceptionalism with mental health predictions, right? And the other thing is the prediction's made and it typically stays in somebody's in the EMR, particularly if it's made with an EPIC. And so the prediction is discoverable. And so you also have to think about that aspect of it, is that the patient, if you don't tell the patient, they still may well find out about it. I actually think that may be a role for Gen AI, is to initiate these discussions with patients, and they'll be able to meet them at their level of medical familiarity. So thank you for that. I appreciate it.
So it's such important questions. And one of the things that in terms of that we're working with the Ocean team, one of the informaticians who's a primary care provider suggested, one of the things you can do is you can have on the health maintenance things, colon cancer screening when you're 45, get the flu vaccine every year. We can have PrEP discussion because it's USPSTF grade A recommendation, and the CDC says discuss with everyone. And then if that kind of is overdue, then you can have an alert that goes to patients that says, hey, this is overdue, please talk to your clinician about it. And you could also provide PrEP information that way. So it's again, less, people not being singled out, but this is something that everyone has on their health maintenance.
Thank you. I think there's another question. So Barbara, go ahead.
Yeah, thank you. Barbara Bennett, I'm a healthcare and transactional attorney, actually, who does AI governance. And all the issues that you've been talking about and that Charles raised, obviously, are ones that governance looks at, bias and all that. But I've got another question in terms of strategy. And that is, given recently, federal agencies, DOJ and others, are really looking at EHR recommender systems when they recommend certain drugs or therapies very closely. And it grew out, of the opioid issues, which involved recommendations of opioids that led to overprescribing. Why is it important to target and recommend a specific therapy rather than just the discussion? I mean, rather than saying this is a patient that may have HIV risk, you should discuss therapies or actions or risk mitigation techniques or whatever. Why is it important to say you should target PrEP? I mean, that's my question.
Yeah, I really appreciate the question, Barbara. I think it's really important that we don't think of PrEP as the only tool, and it's part of a comprehensive kind of sexual health discussion. The reality is, even though we focus a lot on PrEP because PrEP is so effective, and it remains probably one of the tools that we hope will kind of turn the tide on the HIV epidemic. But the tool and the education in terms of how we implement it talks about exactly what you're talking about. HIV testing, knowing your status, things like condoms, STI testing. It's really more of a comprehensive suite of things that are discussed. But we do emphasize PrEP because we know that it's a relatively high bar for clinicians to talk about and prescribe PrEP if it's not something they do a lot, or if it's not something that patients are already really engaged with from their community, and they've already been educated outside the healthcare system. So we want to balance and say that there's lots of things to discuss. And we actually think that PrEP discussion is the right metric, like you're suggesting. And really, it's in the framework of shared decision-making, that we're not saying that everyone should be on PrEP, but that everyone should be offered PrEP and be empowered to make an informed decision. And I think right now, in terms of, the metrics, in terms of informed decisions, you have to have information, and you have to have an understanding of what options you have available to you. And we think that most patients in this community don't have either information or an understanding of options. So the real goal is to have clinicians do exactly that, as opposed to PrEP forward. And I think it's a good, I'm reflecting as you say that I think a lot of the titling and the terminology in these talks and things are all PrEP, but we should take a step back and say this is really about more comprehensive sexual health and HIV prevention. And we've actually talked to the OCHIN providers about how should we frame this. And the primary care providers, who are also the informatics experts I was mentioning, kind of said to us, if you just frame this around PrEP, a lot of PCPs are going to turn off and think this is sort of not my wheelhouse. I don't really want to do this. I'm not comfortable doing this. This is for other providers. And so we've shifted the framing a little bit more towards what we're trying to call high impact HIV STI prevention, and that the education and the actual things that go into the tool are not just PrEP. They're going to also be around a broader swath of things around HIV prevention. So I think it's a good point. One of the analogies, though, I think that may differ from opioids is that I think we've seen, after 12 years of FDA approval, no evidence of overuse of PrEP causing harm. We've seen oodles of evidence of underuse of PrEP, leaving benefits on the table across the country. So I think, this came out with a risk mitigation strategy when they first came out with PrEP. And there were like all these contracts to sign with patients. You're going to use PrEP appropriately. And I thought these were just totally inappropriate and counterproductive in terms of stigma. But that's just my opinion. And I think those have more faded by the wayside.
Yeah, I don't think it's comparable necessarily, but it's just, if it involves any kind of reimbursement funds, it can get triggered at some point. As that's all. I just recommend our systems. I think you just need to be aware and think through the questions.
Yeah,
It's a great point.
Jennifer and then Martha. Yeah.
Hi, thanks. I'm Jen Cortez. Can you guys hear me?
Mm-hmm.
Okay. I'm a primary care physician at a federally qualified health center, so I really appreciated your talk. And I did want to say just briefly that the specific medication suggestions are really helpful in terms of efficiency, and also allowing our staff who maybe does not do this type of care on a regular basis to be a little more confident in the decisions that they're making. And so from the clinician standpoint, at least, I think it's really helpful to have the specific kind of standard of care outlined in these order sets or suggestions, I guess. But my question for you is actually a little bit more in terms of how did this get executed sort of at the FQHC level? How did OCHIN, were you guys involved in identifying partners? How did OCHIN identify partners? We're pretty early on this journey and just trying to learn more and understand how to kind of prepare ourselves to be able to participate in these types of programs in the future. So just kind of curious about your thoughts on what was needed within these community health centers to allow you to implement this successfully.
Great question. So OCHIN has a long history of doing lots of different research projects in terms of implementation of clinical decision support, because they have that structure of a centralized Epic installation that feeds all these different health centers around the country. So they do this for diabetes care and cardiovascular disease and social determinants of health. So they have a whole infrastructure and experience and a mechanism for recruiting sites. So they'll basically say, of the several hundred health centers in the OCHIN umbrella, they'll say, we have this PrEP project, who might be interested? And then people kind of volunteer, and they have they pay the clinics for the impact fee of participating in the research. And it's kind of a whole ecosystem that they have, and that's really made it easier. We also looked at using OCHIN data, which health centers have high HIV incidence and low PrEP use, to try and find sites. And then we've preferentially tried to court those sites to participate. We've only had the pilot study. We're still recruiting for that big stepped wedge study. So more to come on whether we successfully engage the clinics that we think would be the best fit, but happy to talk to you offline as well about some of those conversations.
Awesome. Murtaza, go ahead. Sorry, I know we are at time, but can we take one last question and then we can,
Hi, thank you for the great presentation. I just wanted to note there was an article recently out published in one of the journals about the HIV provider status. And so this is Kaiser. They did a predictive model where the clinicians who were not HIV providers, so they didn't have a lot of HIV patients or high-risk patients, did not get benefit from the predictive model. Their patients did not get benefit, versus the ones who were did see a lot of higher risk patients, did see a significant benefit. And so this goes to the whole discussion around the difficulty of the conversation. And I like the idea that was suggested by the clinic about, rerouting patients to somebody who is good at having this conversation, because it sounds like clinicians who don't have this conversation often, I don't think it's even just a values Bible Belt issue. It's also just a hard conversation to have. And so, yeah, just wanted to see if you had any other thoughts or comments regarding that.
Yeah, great. Murtaza, a great question. And Jonathan Volk, who's on the call here, I don't know if he's physically there, is the first author of that study, so can comment more about the details. But I think it speaks exactly to what you're suggesting, which is, this may not be a one-size-fits-all approach. Some clinics, they're going to have to engage providers to make have the discussions and prescribe themselves. But other places, like at Kaiser, where they have a system where Jonathan runs the PrEP program, and so PCPs are really asked to refer to an expert team as opposed to get it all done themselves. I think it's a much lower bar in terms of the ask. And so that's a really good model. So I think it'll be, tailoring it to the local populations. I don't know if Jonathan has any last comments before we close.
Can you hear me, Doug?
yes.
All right. I'm in the hospital, so my audio is not fabulous here. Yeah, no, I agree. I think it's not going to be one size fits all. I mean, we had some challenges in our study we were implementing right during one of our COVID peaks. So I think, there was definitely competing priorities and time constraints for our providers. And I think some of our docs are just more excited and engaged about PrEP care. Excuse me, and more comfortable having these discussions. And so I think having options for PCPs to directly refer, maybe utilize kind of newer technology like e-visits and outreach to patients, Doug, as you were referring to earlier, that discussed kind of more general preventative care, including PrEP, so that people would not feel like we were targeting necessarily, but just making sure people were aware of all the resources that were available. So I think we have the tool, we have the prediction model, we know it works well, and now we just need to figure out the best way to actually make it happen in the primary care setting.
Awesome. Thank you so much. I know we're a little bit over time. Thanks for joining us on this month. And just a quick announcement for the next month's Health AI Hub. The registration link is uploaded on the website, and the topic would be around augmented intelligence and medicine and healthcare initiative. So AIM High initiative. So Dr. Vincent Liu from Kaiser Permanente will come join us next month to talk about the AIM High initiative and some of the overview of the projects that are funded through that initiative. So we'll look forward to seeing you guys over there. Thank you so much. Thank you. Thanks, Doug, for a wonderful presentation as well.